All right. Hi, everyone. So, this is our second to last lecture in our class. It's amazing. Thanks for hanging in there. You guys are doing a fantastic job. And as always, you're welcome to email me or call me or whatever you need at this point in the semester. I think the stretch between spring break and finals feels a little long. So if you're finding your attention waning a little or you need a little extra boost, please reach out to me. Okay, so today we're going to talk about randomized controlled trials, and this is the last study design that you all are going to be introduced to in this course. So let's go back a little more. So right after spring break, we learned about cohort studies and case control studies, and those are our two types of observational studies that are really commonly done. And then we sort of learned how to do them, and then we talked about bias and confounding, which are the concerns that are raised in these particular types of study designs, and specifically when we are sort of watching populations who are naturally exposed or unexposed to certain things and either following them over time or having to collect exposure data that happened in the past. And basically there's sort of a lot of errors that can be introduced and a lot of confusion over what are the exposures that actually play a causal role in our disease outcomes versus are just sort of along for the ride. So that's what we've been doing for the past couple of weeks, and you guys should be really well versed in what are the characteristics of cohort and case control studies, and then again, what are these sort of errors or confusions that happen because we're using observational data. And so you should be really familiar with that. And now this week we're going to talk about randomized control trials, and this is the gold standard design of epidemiologic studies, and you'll see why, because if done correctly, they enable us to overcome a lot of the pitfalls of prior observational research. So they're really wonderful in some ways, but there's also, a lot of potential problems. Like we can't always randomize people to an exposure or not. So we're limited and we go back to our observational studies, but we'll talk through all this. So that's where we are. That's sort of the background and the framing of how we got here today. Okay, so here is a brief diagram of the epi study designs that we've talked about. So we have our descriptive studies, and in this course we talked about our ecological studies and our cross-sectional studies as types of descriptive studies where we were able to describe person, place, and time in terms of our health outcomes. They'll look at preliminary associations between exposures and outcomes right at one point in time, so we can't tease apart temporality, what came first. But they're hypothesis generating. They say, oh gosh, what are the questions that I'm interested in next, or what questions does this raise? Then we also looked at our analytic study designs, or our analytic epidemiology, and this is where we go on to try and understand the determinants of health and disease, where we are testing our hypotheses. And so far we've talked about observational studies, as I've been saying, cohort and case control, and now we're going to talk about essentially experiments. And we'll go into this in depth, but we can do experiments or RCTs with individuals, so we can randomize individuals to an exposure status or not exposed. And then we can also randomize groups, and we'll talk about what that means. So there, if that helps you sort of frame all the stuff we've been talking about in our course so far. So what's a randomized controlled trial, or an RCT? That's what I would probably say to describe it shortly. So it's a study design where the investigator manipulates the exposure to determine the effects of exposure on the outcome. Bottom line, it's different, right? In observational studies, people were exposed or unexposed based on choice, based on where they lived, based on nature, based on actually genetics or some other biological factor. Here, us, the investigators, are manipulating the exposure. We're assigning people or groups to be exposed or unexposed. And then we watch what happens, and so we can see the effects of that exposure on our outcome. And so the way that we determine the effects is that we look at changes in our exposed group compared to changes in our unexposed group, or our comparison group. Think about our incidence measures, right? Here again, we have two groups. We have one exposed and unexposed, and we can watch the number of cases of our health outcome that develop over time. So again, we're coming back to being able to assess relative risk, which we couldn't in our case control studies. And the determination of which group will be assigned, so whether you're exposed or unexposed, or in some cases, if there are sort of multiple exposures that we're testing, is determined by random chance. And we'll go into that in a minute. So here's a schematic of RCTs if this helps you think about things. So we have our study population. We recruit people into our studies, and often with certain inclusion and exclusion criteria about, who we're trying to understand in this study, who we think would be a good and compliant research participant, especially if it's sort of a difficult protocol. We recruit people into our study, and then we randomly assign them. And in this case, it talks about current treatment versus new treatment. Those are just specific things. It could be no treatment versus new treatment, or 3 treatments. But the bottom line is that we recruit people, they're randomly assigned to exposed and unexposed, and then we watch them and to see how their health changes. So in this schematic, it's talking about improving health or not improving health. So you can imagine this schematic might hold true, let's say for type 1 diabetics, and we want to see if a new insulin treatment regimen controls blood sugar better. So we would have our study population of diabetics that we recruit. A proportion of the people are exposed to the current treatment protocol, a proportion are exposed to the new treatment protocol, and we watch their glycemic control over time. So you may be picking up a little on my vocabulary, but just to be explicit about it, exposures, often in RCTs, they're known as interventions or treatments. We may have a treatment protocol about what the treatment should actually be. These words are all used interchangeably. I often talk about intervention condition being which exposure has been assigned to a person or a group. So which condition are they in? Are they in the exposed group, in the unexposed group? Are they in the current treatment versus new treatment? That would be your intervention condition. So examples of this, intervention versus control, are sort of the simplest and most common types of intervention conditions. As I said, we may have a new intervention versus usual care. So what would normally happen to these patients? And then, as I also said, we may be testing multiple interventions, right? You may want to do a study where you look at what is the effect on weight loss of a dietary modification intervention alone, a dietary modification intervention with a physical activity component, or nothing. And in that cases, you can have 3 arms to your RCT. And as I said earlier, RCTs are really considered our gold standard. They're the best choice for testing the effect of an exposure because, again, if you do them correctly, we can bypass a lot of the concerns about bias and confounding that we've been talking about in recent weeks. So let's talk about experimental units. As I said, we can do RCTs using either the individual, so a specific or an individual person, or a group of people as our experimental unit, meaning sort of what level we assign our exposure to. Do we assign exposure to individuals or to groups? So when our experimental unit is individuals, it means that individual people are randomized to an intervention condition. So you can imagine a group, say a classroom of 30 students. Each individual student would be randomized to receive the intervention or some sort of comparison or control condition. And this, having the individual as the experimental unit, is useful when an intervention works directly on a person and when assignment of an intervention to a person won't affect others in the study. So the best example of this is in an RCT that's testing the effect of a new drug. So the idea is that when a group of individuals will be randomized, some will be randomized to take the drug and some will be randomized, say, to take a placebo or an inactive drug. That drug, we believe, will work only on that individual, right? So the person taking the drug is going to get the benefits, if there are any, of the drug. And that person taking the drug and getting its benefits is not going to have any effect or sort of spillover onto the people around them. So one person taking on a new diabetes, insulin protocol, the positive effects on their biology and their glycemic control don't affect the effects of the effects of glycemic control of the diabetic sitting next to them, right? The mechanism of action is all about the individual, and it doesn't spill over to affect other people. So that's when we want to randomize individuals, when we think that this program will affect that person who is randomized to the condition and only that person. And you'll see the comparison when we talk about groups in a minute. It'll come in to be clear. So examples of this, as I was saying, are when individuals are randomized to either take an active drug or a placebo. That's when the unit of randomization and the experimental unit are individuals. Or, for example, if an individual is randomized to receive a new screening test for prostate cancer or receive the standardized screening test. Again, if you go into a doctor's office and if half of the patients are recruited to receive the new screening and half are receiving the standard screening, what screening one person got doesn't affect the health status or the outcomes of the patient after them, right? It's all about that this intervention is working individually, specifically on that person. The alternative is when our experimental units are groups and when it makes sense to run studies where groups are our target of our intervention. And this is sometimes known as a group randomized trial. So there may be some things that you want to test in an RCT design where communities of people or groups of people are randomized to the intervention condition. And when this happens is when your intervention, what you're testing, can only be applied to a group. So for example, let's say, and I think I have examples down below, but say I was testing a new curriculum for epidemiology, right? I couldn't stand in front of a classroom of 30 students and give every other person the new curriculum and every other person the standard curriculum, because you're all in the classroom together, right? By design or by necessity, the entire classroom needs to receive either the new intervention or the new curriculum or the old curriculum. It's not possible to break people out. So that's when we would have a group as our experimental unit. We would randomize to intervention condition or control condition. We randomize groups and not individuals within groups. Another example is if we're thinking about families, right? And if you have some educational intervention that you believe works on families and that, you sort of need buy-in from all family members, and one family, say if mom is doing really well in the study and is really jazzed about it, she's probably going to affect her kids and, maybe her spouse to be really excited about the intervention. In that case, again, you wouldn't go into families and assign, mom to get one education intervention and kids to get a different one. It doesn't work like that. We expect that the group will work together. And oftentimes, we actually want, in group trials, we want the group to work together. We want there to sort of be this spillover and this energy so that our intervention works even better, right? A lot of times we're hoping that people get really excited about a new curriculum or get really engaged. If say there's a new seatbelt law, right? We want families to sort of talk to each other and say, gosh, we really need to put on our seatbelts. And in RCTs, this sort of spillover to other people is known as contamination, right? And typically contamination is seen as a bad thing. So people often worry about in randomized control trials, like if I assign, one person to get my treatment and their next door neighbor to get my, to be in my control condition, is there going to be contamination? So say my intervention was a new diet, and we've now assigned one neighbor to be on like the new high carb diet or something, right? And their neighbor's not. We may be concerned about contamination because what if one neighbor makes a really delicious potluck dish, brings it to the party of the neighbor next door and talks all about the benefits of this new wonderful high carb diet, right? That's contamination. That's going to mess up our RCT because our individuals are not independent of each other. They're affecting each other. They're talking about these things. So the point is that when we do RCTs where we randomize individuals, we do not want contamination. We do not want the treatment that one person is assigned to be affecting another person who's in our study. When groups are our unit of randomization, our experimental units, we want that contamination. We want our interventions to work through diffusion of information and excitement and getting everyone on board and sort of like lock and step behavior change. So again, some examples of when we would assign groups as our experimental units. Say we want to know about different smoke-free workplace policies, right? So, obviously no workplaces have smoking anymore, but do they allow you to step outside to smoke? Do they allow you to smoke during breaks? Whatever it is. Again, we wouldn't assign individual workers, one to be affected by a policy and one not. We would want to randomize and intervene on the entire work site. So a new policy is coming into this work site. It's compared to another policy that was assigned to just their usual policies. And we look at the difference in smoking behaviors across those two work sites or across multiple work sites. Another example, which I mentioned, schools are designed to implement a nutrition education curriculum, right? So school is the unit of randomization. Everyone in the school is on board, and hopefully there's some diffusion and some excitement about the new knowledge being learned. Again, families, say we wanted to do parenting counseling, you would want to do that with your family as the group of randomization, not the individual, because you don't want, mom and dad or mom and mom or whoever's in the family to be getting two different curriculum. It's not going to work. You're going to be completely contaminated, and you want to build on the excitement and that diffusion. Okay, so we've been talking a lot about randomization. Specifically, what is it? It's a method of treatment allocation where the treatments are assigned by chance. And the key pieces of this are that all randomized units, so whether we're talking about individuals or groups, have the same chance of being assigned to any one of the potential treatment groups, and they have an independent chance, right? So say you have a 2-arm trial where you have your intervention and your control group your control group gets nothing or usual care. Say you decide that your split is going to be 50-50, that half the people in your study are going to get your intervention, half your people are going to be your control. You want every individual who comes into your study to have the same chance of being assigned to your treatment group. So every individual should have a 50-50 chance of ending up in either of your two groups. And they should have an independent chance. And so what that means is that the treatment allocation to one person shouldn't affect the treatment allocation to the other person. What that means is that you can't have it be like, okay, well, my treatment allocation, the way I'm going to randomize is that the first person who comes to my clinic in the morning is going to be treatment, the next person control, the next person treatment, right? Because in that case, yes, they sort of all have a 50-50 chance, but like once that first person comes in, the next person is going to actually have a 100% chance of being assigned to the other group. It needs to be they all have the same chances, and what group they're assigned to is independent of each other. And the key is that a really important thing, and we'll talk about why, is that you want it to be impossible to know in advance which group a unit will be assigned to. So you absolutely do not want a case where like first student, in your you go through your class alphabetically, first student is intervention, next student's control, because then you're going to be able to say, oh, I can see the 20th student down there and they're going to be assigned to intervention, right? Because what starts to happen is that, say there's some reason why you don't want them assigned to intervention, you're going to be like, hey, can you like move over seats or like be out absent this day? And we'll talk about why. Then once you start to interfere with randomization in that way, you introduce back in all these errors and biases that we've been trying to avoid. And you'll see why in a minute. Okay, so we just talked about sort of how we randomize. Let's talk for a minute about why we randomize, because randomization, this sounds a little dramatic, but randomization really is this miraculous thing that, as I've been saying, allows us to avoid a lot of the problems in observational epi research. So what randomization does is it balances differences across groups, as long as we have enough people to randomize. Right? So the idea here is, let's think about confounding, right? The problem of confounding is that your exposed group, your people who are exposed and your people who are unexposed are different in potentially lots of ways other than the exposure, right? You may have different racial distributions in your exposed and unexposed group, different gender distributions, different age distributions, right? And that's messing you up. You can't tease apart what is the effect of your exposure with all these other things that go together with your exposure. Randomization balances those differences across groups, right? So it's I wish you guys could see me because I often use my hands when I'm trying to describe this. So say you have a really multi-ethnic sample of people who want to be in your study. So you've got a big mix of, white and Hispanic and Black and Asian and low income and high income, right? And they're all coming into your study. So what happens is as you randomize people, your intervention, your control, your intervention, each person comes up and you randomize them to one of your groups. If you have enough people, all of those differences in your study sample get balanced across the groups, right? If you can imagine, and we're going to see some images of this, enough people coming through and you're like, okay, we've got a Black man over here, we've got an Asian woman over here, we've got another Asian woman over here, right? They're each sort of going into their two groups, and eventually the racial and ethnic and economic compositions of your two groups are going to look like the composition of your main group, because you just sort of randomly split them in half. It's not like people have purposely gone to one group because of their likes or their dislikes or whatever it is. You have forced them to separate and to be in these two groups where overall, on average, the distribution of third factors or confounders are balanced across these groups. So what happens? So the exposed and unexposed groups, as I've been saying, are similar on all outcomes that affect the occurrence of disease, right? These two groups on average look the same in terms of demographics, in terms of income, in terms of health behaviors. And it's not like you specifically pick people and said, I want a smoker over here and a non-smoker over here. When you randomize a large enough sample, that will happen naturally. And so then the super cool thing about this, it's very exciting, right? You have now balanced all your confounders, all your third factors. They can't distort your exposure outcome relationship anymore because they're balanced. They're equal. It's not like there's, more Black people in one group or more white people in another. It should be on average balanced. And so it balances all your known confounders, like all the things you would be concerned about. And the other cool thing is that it balances all your unknown confounders. Like, what if there's some third factor that you didn't even realize was going to screw up your study? Well, now, because of randomization of large numbers, it doesn't matter. You don't even know about it, but you can feel good that it's balanced across your exposed and your unexposed groups. So the end result is that confounding is eliminated, and amazingly, all of a sudden, your control group or your comparison group now can serve as the counterfactual to your intervention group, because on average across your two groups, the only thing that's different is your intervention. Okay, that's like a major sort of like a light or an explosion should go off in your head. So if you don't sort of get that intrinsically, like, let me know and we'll talk about it some more. Okay, so here's a little visual, right? We have up here our big population that's, built of all different types of people. We randomize where some are going into our control group and some into our exposed group. And these factors, with only a few, you might start doing it in like first only old people get into your control group and only young people into your exposed group. But over time, with enough people, you're going to balance all of these differences across your two groups. Okay, so first of all, randomization protects against bias. Remember, we talked about bias it's errors in the way we do our study, in who comes into our study, who stays into our study, the information we collect. And bias results in a systematic, incorrect conclusion about the relationship between your exposure and your outcome. When you have bias in your study, the relationship you see, either that odds ratio or that relative risk, is going to be wrong. Okay, so randomization protects against selection bias and information bias. So since subject's assignment to a treatment group is determined after enrolling in the study, we have this population of people who say, I'm interested in being in this study, and then they're randomized, potential for selection bias is greatly reduced. I have an example on the next slide because I think this one is a little tough to pick up on. The other piece is that information bias is reduced when exposure status is assigned. So we're not dependent on anyone's memory. We're not dependent on them remembering what they ate 20 years ago or their incomplete medical records. We know what their exposure is, right? Much better than a case control study where we have to essentially guess sometimes. And then the other way information bias is reduced is when participants and or our investigators are blinded. So your most familiarity with this idea is probably in a drug trial, right, where someone gets a placebo and they don't know whether they got the placebo or the active drug, right, because they have to have a blank little prescription bottle and it looks like pills. That's blinded. So you're unaware of what you're getting. So that individual, if they don't know whether they're getting the placebo or the active drug, they're just going to report their side effects. They're not going to be more or less likely to report side effects because they think they got the active drug versus not. They're just going to report what's been going on. Often, we have something called double-blinded where our investigators are also blinded to what, whether someone got the active drug or the placebo. And then it can't even be like the research assistant is like, oh, so you've been on a pretty powerful drug. Do you have any side effects, right? We talked about how that can happen. That's not going to happen if that research assistant doesn't know what drug you got. They're going to ask everyone equally, are you having any side effects? Okay, so here's some specific examples. So selection bias. So say a researcher believes that a smoking cessation program will work better with people who are not depressed. If she knows the participant's assignment ahead of time, right? If she knows that someone's going to get selected to go into the smoking cessation program and other people are going to get their usual care, she can do things to make it less likely that her depressed patients or participants stay in the study or even are enrolled in the study, right? She could sort of unintentionally be like, oh, I don't know if we want, I know you're going to end up in the intervention group. I don't know if we want you there. Like maybe we can, this is all sort of unconsciously, like maybe we can change your appointment time so you end up in the control group, right? So when you start to be able to predict which group someone's going to be assigned to, there are all sort of little tricks and things that you can do that end up introducing selection bias into your study. So we want our assignment to be random and unpredictable. So there's nothing that anyone could do to make it, say, harder for someone that they maybe don't want in their intervention group to like be assigned to their intervention group. Okay. As I gave this example in the last slide, so we can reduce information, or an example of information bias. So say in a drug trial, if the person collecting data knows who's on the active drug, they may look for success in that group a little more. They may prompt them a little more. They may look at lab results a little differently. Similarly, as I mentioned, they may look for side effects a little differently. And that sort of digging or extra attention to people they know got an active drug or a placebo is going to mess up your findings, right? You're going to be more likely to see a certain outcome in one of your groups than the other. It's going to be just a byproduct of you looking, not like an actual difference in actual disease states in your two groups, and you're going to end up with a wrong answer. Okay, so how do we do specifically randomization? There are a lot of ways we can do it. A lot of people rely on a table of random numbers it's actually even like a paper table, old school, or your computer systems can generate random numbers. I always joke, I worked on a study, like 15 years ago where we had this envelope system of randomization. So like a participant would want to be enrolled in our study and we would go out to their house, and the last thing we would do before like leaving the office and going out to their house was pick up this closed envelope. When we arrived at their house, we would go through their, initial screening form and data collection to get baseline data, and then we'd like open the envelope and it'd be like, surprise, you were assigned to the intervention condition or you were assigned to the control condition. So that's sort of the old-fashioned way of doing it. And I actually, for small numbers, I actually still do it that way. I just sit here and stuff envelopes, and my research assistants then can open their envelope like, hey, this is what you got. There are sort of specific things that we can do. So in the case where you were doing a study that only a very select number of people would be eligible for, say it's like an experimental treatment drug for a rare disease. If you're concerned that there are not enough potential people in your study to successfully balance your confounders across your exposed and unexposed group, we can do some things to try and help that balancing. So first, we can divide our subjects into groups based on your potential confounder first. So say you want to make sure that gender is equally distributed across your two groups. What you can do is when people get enrolled in your study, you can match. Say you match, pairs of women, and then you randomize within that match, and you know for sure, right, that one woman is going to get assigned to the intervention condition and one woman the control condition. You don't know which is which, but you now know that you've balanced gender, you've forced gender to be matched across your two groups. The same thing is the idea of stratified. So like instead of just matching one-on-one, you can say, I'm going to, take my group of women who are eligible, randomize within them, take my group of men who are eligible, randomize within them. Blocking is another way to sort of ensure better randomization. So the idea here is that, say you think that the time of enrollment matters to your how your study goes. So to say you want to make sure that like within month 1, you have enough people to do your education group, to run it successfully, right? So you wouldn't want to just let people be randomized, and just because, sort of the rules of random numbers, you may not within month 1 get enough people to be in your intervention condition. So you may say, everyone, we're going to take the whole pool of people who are eligible within month 1, randomize half to intervention, our education, and half to control. Then we're going to take within month 2, half to intervention, half to control. And that way you've assured yourself that you have enough people to like do your intervention if say it's, necessary for a group basis, for it's, depends on a group, or say it like depends on, hiring a nurse to go do your intervention. If you want to have some control over the timing and not leave it all to random chance that you could potentially have like 10 control participants and no intervention participants within the beginning of your study. Okay, so we already talked a little bit about blinding. Specifically, it's concealing the treatment group status of your study subjects. So you don't know who got what, who got intervention, who got control. So we can do a single blinded where the subject themselves doesn't know what they got. They don't know what treatment condition they're in. We can also do, as I said, double blinded where the subjects and the data collectors don't know who's in what, and they're just collecting their data with sort of everyone looks the same. We can also do it later where the analysts don't know which group they're dealing with, which is intervention and which is control, and that sort of protects against some bias that the person doing the data analysis might say like, oh, I think I see something and this group seems to be doing a little better. But an important thing to realize is that very often actually blinding is not possible, and that's especially true for our behavioral or our policy level interventions, right? So if you're assigned, like you're in a study that's testing this high carb diet, like if you get your dietitian, you meet with their dietitian and they're saying like, oh, 80% of your diet should be carbs, you think like, oh, I know I'm in this active condition. I always tell the story when I was right out of college, and I worked at a hospital and I signed myself up for every study that was possible to get a little extra money. One of them was actually on a medication to treat acne, right? So, people with like mild to moderate acne would take this medication, they'd see if their skin cleared up. Well, I won't go into details, but this medication had pretty severe side effects. So, and I don't think they were not placebo, like they were known side effects of this medication. So like as you start taking it, you're like, oh, I'm experiencing this. And so basically, I knew which condition I was assigned to then. Okay. So let's think, so once you have your participants enrolled in your study and they're randomized, now you need to deal with compliance. So how good are your participants going to be at adhering to whatever treatment protocol or intervention protocol they've now been assigned to? So often in the intervention condition, or unfortunately often, intervention condition subjects may not take the drug as prescribed, they don't adhere to the diet that is assigned, they don't implement policies that are expected of them, right? And there's a lot of reasons why. Maybe you have a really arduous study protocol and you're asking people to eat, a diet that's like 5% fat and they're just starving all the time. Or I had a student in my class a couple years ago who was telling me that he signed up to be a participant in a study, and taking the study drug involved injecting himself. And he just realized, he thought he could do it. He signed up. He said, yes, I'm ready to go. And then he just did not want to do it. There's just a lot of reasons, especially in more difficult trials and more difficult situations where people in the intervention just don't do what you hope they do. What also might happen is that control subjects drop into the intervention, right? So say you're running, and this actually happened with something called the Mr. Fit trial. Say you were testing the effect in Mr. Fit. They were testing the effect of a low-fat diet. It takes years to get these studies running. So they're all set to go. They have people assigned to the low-fat diet versus the regular diet, just eat as usual. They think they're doing well. And then, in the early 80s, the low-fat craze took off, and there were media, things in the news and all these stories about how great it was. So all of a sudden, your people who are not supposed to be changing their diets are changing their diets, right? And that's completely, we hope they wouldn't do it, but that's sort of their choice if they want to start eating in a way that's they believe healthier for them. And then, another example, so, say you're testing the effect of a vitamin, or, folic acid supplementation, right? And then all of a sudden there's some change in policy or the food industry, and foods become fortified with folic acid, is what happened in our country, right? We can't actually in our country test the effects of folic acid in a randomized control trial because so much of our food supply is fortified with breads and cereals and all that type of thing. So you can start to see situations where people in your control condition start to look like people in their intervention condition. And in both cases, so whether it's your intervention people not doing what you asked of them or your control people doing what you don't want them to do, your intervention and your control conditions start to look more similar. And you can't then, whatever effect, if any, your intervention's having, you're going to only see that effect a little bit because your two groups are really not as different from each other as you'd like them to be. This has just been a problem that's like continually plagued diet studies, again, because people just don't like to change the way they eat on a long-term basis. So we see very little effective diets oftentimes because people are not as compliant as we would hope them to be. Some non-compliance can be controlled. There are methods like, so there, like for drug trials, there are pill bottles that sort of track how often you open them, or like you tell your participants, like, I need you to bring in the empty, silver pouch things that your drugs came in and show that you popped one out every day, right? And not only does that allow the study to record how often you took your pills, but it's a bit of kind of coercion. If if you're a subject and like, oh gosh, they're going to be looking at like the timing of the opening of the bottle cap, you're probably more likely to take your study drug. We can also reduce the complexity of our study protocols. Maybe that drug that required the shot, maybe it didn't actually need to be in a shot form, or maybe they should have recruited a study population that was more used to giving themselves shots. I don't know who that would be, maybe nurses, right? So there are things that we can do to increase compliance, because compliance is a huge issue. If you design your study and you randomize people and people aren't doing what you want them to do, there's no point in this study, because if you don't see a difference in your two groups, you don't know if it's because your actual intervention doesn't work or if the people didn't do what you wanted them to do. So how do we improve compliance? I talked about this a little. You can simplify your regimen. You can enroll people who are motivated and knowledgeable. So example, like enrolling nurses because they may be more comfortable with some medical process. You can present a realistic pictures of the tasks required in the study. You should always do this, right? You should always be very clear about this is what's going to be required of you, and do you believe you can do that? You can obtain detailed medical history or even conduct sort of psychological assessments on people to exclude people who would have a difficult time with compliance. Maintain frequent contact with participants, check up with them, make sure you can answer any questions. And then finally, conduct a run-in period. So what this means is saying, like, we're gonna recruit you into our study, And like for 2 weeks, we want you to follow this drug treatment protocol. And basically, we're going to see if you can do it. I mean, you don't necessarily tell them that, but it's just you're going to see who's going to do it and who drops out and who can't keep up with things. And then after that 2-week period is when you're really randomized to the conditions that you care about. All right, so let's talk about generalizability of the findings from our randomized control trials. So what this means is that, so there's a concept of internal validity. How correct are the answers that you obtained from your trial? Is this the correct estimate of effect of your intervention? Did you have a great study population who complied with your intervention protocol? Did you measure everything correctly? And so the answer you get is really good. That's internal validity. Is it the truth internal to this study sample that participated in your study? Then there's this idea of external validity, which is essentially like, how true are these findings for the general population? If we rolled out this exact treatment protocol to our general population, would our findings hold? So the issue with generalizability is that the people who volunteer to participate in studies tend to be different than the general population. They're generally more compliant. We know they tend to be of white race and older, and they tend to be more motivated by financial incentives. So in whatever way you think that would make someone different. So these are just like, good patients, let's say, and they're, ideally they're sticking with your protocol and think about confounding again, like they're like healthier probably than other people. They're more like health conscious and things like that. They're going to be different, right? So you can run the best study ever and find an effect among this slightly different population. It's a true effect. It's a true difference between your intervention and your control among this group. But in a way, you have to think about like, how much do we care about these effects if the group of people participating in our study is not representative of the population I really care about? So as I was saying, having these select groups of people participate in your studies affects the ability to generalize your findings to the larger population. And that's this idea of external validity or generalizability. In general, I think that, it's sort of like an easy, like low blow. I can't, for someone to say, oh, your study's not generalizable. Like, I think we need to think, and that's something you commonly hear, like, oh, those findings don't generalize. I think we need to start thinking beyond that, though. Like, do you really, if your drug, let's say, shows an incredibly powerful effect among this population, do you really think it's going to be that different if you go to a less healthy population? Maybe it will, but maybe it won't. So I think it's sort of, again, an easy response, like not generalizable, but I think it takes a little more thought to think about, like, does that actually matter? Do I actually think my results will be different once I go to the broader population? Okay, so we've done our RCT, we've recruited people, we've randomized, we've made sure they're compliant. So how do we assess outcomes, or what do we care about? There's a lot of different things we could care about in RCT, right? Like, it all depends on your research question. Like, what's your outcome of interest? We may care about the change in the presence of risk factors. So like, did a smoking cessation program actually help people quit smoking? We may care about the precursors of disease. Did it change cholesterol? Did it change, immune functioning? Something like that. We may want to prevent the first occurrence of disease. So like, how many women in our study were diagnosed with breast cancer after receiving this drug? We may also, so those are all sort of examples of like prevention-focused outcomes that we care about. We may also think about trials that are therapeutic. So they're trying to help usually clinical populations who've already been diagnosed with some outcome. So, and then we can see, like, does our treatment of interest improve symptoms? Does it allow for greater length of survival? Does it prevent the reoccurrence of disease? In a population that's already diseased, so like a remission of cancer, something like that. The other thing is that often in our randomized controlled trials, we think about primary versus secondary outcomes. So RCTs are complicated and expensive to pull off oftentimes, right? Like, you need to have a big study population, you need to randomize, you need to keep track of people, you need to have a lot of like good, data collectors who are collecting very valid data. So you want to get as much as possible out of your trials. So you may think about like, okay, in my smoking cessation program, my primary outcome of interest is people quitting smoking. That is the main thing I hope to see. That's my primary outcome. But then you also say, I want to understand, in addition to helping people quit smoking, did my smoking cessation program reduce exposure to secondhand smoke for children in the home, right? Or cut down on the number of cigarettes that people smoked? Even if they didn't completely quit, did they decrease their smoking? So things like that. Maybe you can also talk about secondary outcomes and think about like, what is sort of what do I really care about? And are there multiple things that I would expect to see as outcomes in my study? So when we have non-adherence in RCTs, so we have people who are not compliant, we have people who are dropping out, this creates a problem or a question when we go to analyze our data, right? So the question is, do I consider my exposed group exposed and my unexposed group unexposed and compare the incidence of my outcome in those two groups? Or do I actually pay attention to like who was compliant, how much of the drugs did they take? If I had someone who was assigned to my drug intervention, they didn't take any drugs, do I count them as someone who took the drugs? These are big questions. And so the bottom line is, and this actually, if you read that the article I sent out yesterday on AA, it talked about this, and it was a really, I highly encourage you guys to all go read that article. So the gold standard, the best way to approach looking at your findings of your RCTs is something called the intent to treat approach, or intention to treat approach. And what you do there is that you analyze your data and your findings according to which group subjects were randomized to, regardless of what actually happened, regardless of whether someone actually took their drug or ate their diet or whatever it is. Because what happens when you don't? When you say the alternative is using an actual treatment approach, and you have your exposed group and your unexposed group based on how they actually behaved or what they actually were exposed to versus what you assign them to. All of a sudden, if you use that second approach, you're breaking random assignment and you're reintroducing all the bias and confounding that you tried to avoid by running an RCT, right? So there are reasons why people didn't take their drugs, or reasons why people didn't eat the diet that you assigned them to. Maybe it's because they were female, maybe it's because they were younger, maybe it's because they were low income, whatever it is. But now all of a sudden those reasons get tied back into their exposure status. And now you have confounding again. You cannot tease apart the effects of the diet from the effects of all those variables that made someone compliant or non-compliant to your treatment. So we always want to do an intent to treat approach where we compare the people who are randomized to one group and randomized to the other group and compare the differences in those two. So as I mentioned before, when we're looking at how to calculate the outcomes of RCTs, it's just a relative risk, right? We've done this before with cohort studies. We can compare our incidence in our treatment group or our exposed group to our incidence in our control group. So say we have an example of we wanted to do an intervention to provide bed nets to families in malaria-prone areas. So we can look at the cumulative incidence of malaria of children in families who received the bed nets and say that was 0.25. We can then compare it to our control condition, the children who did not receive the bed nets, and the incidence of malaria over the time period of your study was 0.30. We just divide, we end up with a relative risk of 0.83, and so then you can say that providing treated bed nets to families was responsible for a 17% reduction in the incidence of malaria among children. So the really cool thing, so I've been saying this off and on throughout our talk about observational epi studies, is that, observational epi studies provide some evidence of causality, right? We can start to establish temporality and did our exposure come first and things like that. But with an RCT, when you're assigning conditions or you're assigning exposures, you can assess causality, right? Because the only thing different in your exposed and your unexposed group is the exposure. That is causality. You have the counterfactual situation. So all of a sudden when we're talking about our relative risks, you can now say this treatment caused this outcome. And you can say that with confidence. These bed nets were responsible for a 17% reduction. They weren't just correlated with it. They weren't associated with it. They caused it. And they caused it because you assigned the exposure of the bed nets. Okay, this has been a long lecture. I think it's a really important lecture, but I'm just gonna skip over. Don't worry about this. I will not test you on this. I'm happy to talk about it with you, but I think it's sort of secondary, these special designs. And actually that too. Okay, so let's wrap it up. There's a lot of information here. You guys, I've gone through what I think is the most pertinent and what will be on the exam if that's what you're concerned about. So there are some unique issues with RCTs, right? You may be coming around saying, oh, this is so wonderful and we should just do RCTs on every outcome we can, and we should stop doing these cohort studies that are so biased. But there are only some situations where we can do RCTs, right? The exposure must be a modifiable factor. It must be something that you can intervene on, right? You cannot do an RCT of whether certain genetic characteristics have an effect on something else because you can't modify someone's genes, right? And there are some tricky things, like for a long time we've been trying to figure out like what are the outcomes of breastfeeding, right? But it's very hard to assign women, if not unethical, to assign some women to breastfeed and some women not to breastfeed, right? Because we have some evidence about health benefits of breastfeeding. So it's unethical to say a woman can't breastfeed, right? So we have to get around that. And one of the major studies of breastfeeding got around that by saying, okay, we're going to assign one group breastfeeding education and support and the other one just usual care. But as you can imagine, like just providing education and support isn't going to get every woman to breastfeed. So your intervention group, you're testing the intervention of the support and the education and not of actual breastfeeding. Another issue is that the intervention being tested should be sufficiently different from the control condition to justify a trial. As I've been saying, that these studies are complicated and often expensive and difficult to pull off. And you don't want to do an RCT that you think is just going to be like slightly better, right? So like, say you had a weight loss protocol that you believed would like enable people to lose like 1 more pound a year. Are you really going to run a full trial to be able to see a 1 more pound a year difference? Probably not. It's just not worth the investment. We want interventions that have like big bang for the buck. There also needs to be legitimate uncertainty about the effect of alternative interventions on the outcome. So what this means, this is the word, I love this. This word is equipoise. You need to have equipoise. You need to have complete uncertainty over whether your intervention will work better than your control. You need to not, because the reason is, if you already know that your intervention works better or say works worse, it's unethical to, as I was saying with the breastfeeding, it's unethical to assign people to it. Like if you know that your drug, you have enough data to suggest that your drug is really, really good, and say you just sort of want to like do the RCT to put the feather in your hat, like it may be unethical to like withhold that drug from people if you know it's going to have all these good side effects. So there's not equipoise in this situation. And then finally, the benefits of the new intervention should outweigh the potential risks. You may have developed the most, what you believe to be an incredibly effective intervention, and you want to test this. But it comes with a lot of risks, and it comes with, say, a lot of side effects and unintended consequences. Like, you need to make sure you're balancing the benefits and risks of your intervention. And are the people in your intervention condition actually going to be better off than the people in your control condition? Or are there going to be so many risks and so many side effects that it's just, again, unethical to conduct this trial? Okay, so we've got some strengths and limitations of RCTs. Limitations are that we can't always randomly assign a treatment or an exposure, as I was just saying. They're often expensive and difficult. They're not suitable for rare outcomes. So again, if you think about like why we don't do cohort studies. So actually, let's just take a step back. Cohort studies, in a way, maybe I'm confusing you. Cohort studies and RCTs are very similar, right? The difference is we are either like recruiting people based on their exposure status, or we're assigning exposure. But in both cases, we're then watching for outcomes to occur. So that's how RCTs and cohorts are similar. So in the same way that cohorts are not suitable for rare outcomes, an RCT wouldn't be suitable for a rare outcome, because say your outcome of interest, again, I always go back to this, is like childhood leukemia, and you want to test whether like exposing moms to some sort of like I don't know, antioxidant during pregnancy is going to prevent rare childhood cancers versus like usual diet or whatever. So few kids born to these moms are going to end up with cancers. So you may run a whole trial with hundreds or thousands of women and you end up with no cases of childhood cancer in either your exposed group or your unexposed group, right? And then like it was pointless to do this study. So RCTs are not good for rare outcomes. And RCTs are only as good as their protocol, right? So like again, if people aren't blinded, if possible, if your data collection is introducing systematic errors, if people aren't adhering to your study, like you're not going to find anything, or you're not going to like be able to say anything useful about your intervention. So you want good, strong studies. The strengths of RCTs are pretty incredible. As we talked about, they protect against confounding by both known and unknown or observed or unobserved factors. And in a lot of ways, they protect against bias. They really do help with a lot of the concerns that we find in observational epi studies. And so if you can do an RCT, you want to do it. But again, there's cases when you can't. I just want to bring up one other thing. In addition to being not suitable for rare outcomes, right, they're not really suitable for sort of long-term outcomes, right? So like if you care about, like if you think your intervention during childhood is going to have an outcome or an effect on adult health, you're not going to do an RCT and then wait 20 years for these outcomes to develop. So that's another case where you want to consider like either are there short-term outcomes that I could measure that are precursors to later adult health, or do I actually need a different study design to understand what's going on? Okay, so what's the bottom line with RCTs? We mainly use them when exposures can be modified, when there's uncertainty about a new intervention, and when subjects and investigators can relinquish control, right? When like people are willing to be randomized and willing to do what you want them to do. The key design feature is that there's random assignment of exposure. We talked about why that's really important. We can randomize either individuals or groups in our RCTs, and they have a number of strengths, including protecting against confounding and bias, and they really provide the strongest evidence for causality, as I said, that we can see the effect of an exposure because we are, with great certainty, sure that confounding has been eliminated. All right, thanks guys. Have a great week.